The study entitled Coronal 3-Dimensional MRI for Improving Diagnostic Accuracy for Posterior Ligamentous Complex Disruption in a Gold Spine Injury Model was conducted by the doctors from the affiliated Benkei Hospital of Nanjing Medical University of China. I'm the first author, and I'm going to introduce the work on behalf of my co-authors. Background. The posterior ligamentous complex, PLC, is composed of supraspinous ligament, SSL, interspinous ligament, ISL, ligamentum flavum, LF, and facet joint capsules, FC. It protects the spine from excessive translation, rotation, flexion, and distraction. PLC injuries are major causes of spinal instability. According to the recently established thoracolumbar injury classification and severity score, TORCS, PLC integrity is an important consideration for surgical candidacy and may influence the surgical approach. Therefore, it is necessary to accurately assess PLC injury before surgery in clinical settings. Methods for clinical assessing PLC include physical examination, ultrasonography, plain radiography, computed tomography, and magnetic resonance imaging. Palpation is the most unreliable and inaccurate method. Ultrasound is operator dependent. X-ray and CT only provide indirect evidence of ligamentous disruption, though they can allow visualization of osseous anatomy. MRI can directly detect soft tissue injury and is the preferred means of diagnosing PLC injury. However, some studies reported that MRI was highly sensitive but had a poor positive predictive value, especially when severe hemorrhage exists around a PLC, suggesting a non-acceptable false positive rate. Some authors have even questioned the role of MRI for assessing PLC integrity. Normally, ligaments show low signal intensity on all MR sequences. The loss of ligamentous continuity or fluid crosses the location of the ligament are specific signs of ligamentous disruption. Remarkably, this was the exact criteria used for diagnosing SSL and LF disruption in most published articles. In these articles, FC injuries were indicated by either articular liquid or diastasis of the facet joint. ISL injuries were diagnosed by observation of increased signal on fluid-sensitive sequences. However, liquid in the facet joint is not uncommon in non-traumatic patients clinically, and hyperintensity on fluid-sensitive sequences such as edema, hemorrhage, or inflammation. These findings are also associated with ligamentous disruption or bone fractures, but do not necessarily indicate the presence of ligamentous disruption. Using this sign as a standard for diagnosing ligamentous disruption inevitably lowers the diagnostic specificity. These issues highlight the need for further development of consensus-based criteria to define MRI features of ISL and FC disruption or integrity. 3D-dimensional MRI allows thinner slice imaging with no inner slice gaps and enables many planar reconstructed images to be viewed in any plane. Therefore, the purpose of this study was to investigate whether 3D-dimensional MRI could improve diagnostic accuracy for suspected ISL or FC disruption. Materials and methods. We used 20 freshly harvested gold spine samples with 60 segments with intact surrounding soft tissue. All the segments underwent sagittal and coronal still scans, as well as coronal and sagittal 3D PD spot scans. All the images were acquired using 1.5 Tesla MR scanner. Then we created a paraspinal condition model by injecting 10 ml saline percutaneously to each side of the ISL, but not around FC because FC was not clearly depicted on either still images or 3D PD spur images. Following saline injection, all the segments underwent repeated MR scanning using the aforementioned MR technique. Afterwards, some ISLs were cut and all the segments were rescanned using the same MR protocol. After the final MR scanning, each specimen was subjected to a meticulous anatomic dissection by an operator who was blind to the cutting procedure and MR images, and the status of ISL was confirmed by direct visualization. Figure 1 shows percutaneous ISL resection. Posterior, anterior, and lateral fluoroscopic views shows middle crochet hook tip was placed in the anterior portion of interspinal space. These are interspinal processes. ISL was successfully cut out as shown in the following dissection. Two musculoskeletal radiologists independently assessed the images in a blinded fashion to determine tear of ISL on sagittal stole, coronal stole, coronal 3D PD spole, and sagittal 3D PD spole images separately. The image interpretation were compared with the findings in anatomic dissection to determine diagnostic accuracy. As to the criteria for ISL injuries, just as shown in the images, on coronal images, discontinuity of the black stripe and discrete fluid crossing it indicated ligamentous disruption. On sagittal images, linear hypersignal intensity in the interspinal space suggested ISL disruption, while diffuse hypersignal intensity implied adjacent soft tissue contusion. Statistical analysis. The reliability of ISL tear interpretation between the two readers was assessed using the kappa coefficient. The K values were defined as slight, fair, moderate, substantial, and almost perfect. The chi-square test was used to compare diagnostic accuracy among images obtained by different MR techniques. A p-value less than 0.05 was considered significant. Results. 40 out of 60 ISL segments were successfully harvested as confirmed in the anatomic dissection. In the remaining 20 segments, only the soft tissues adjacent to the ISL were cut, with the ISLs intact. Table 1 presents the diagnostic performance in detection of ISL injuries according to different MR techniques. For coronal 3D PD spole technique, the sensitivity, specificity, and accuracy were 100%, 96.9%, and 97.9% respectively, and they were significantly higher than those of sagittal stole, coronal stole, and sagittal 3D PD spole technique. The inter-observer reliability for diagnosing ISL disruption was high for all MR techniques. Conclusion. Coronal 3-dimensional PD spole technique had a significantly greater diagnostic accuracy for ISL disruption compared to the sagittal 3D PD spole and stir techniques as well as the coronal stir technique. In clinical settings, the addition of coronal 3D PD spole to a routine MR protocol may be critical for identifying PLC disruption in cases of extensive nearby contusion. Clinical relevance. PLC injuries are related to fracture severity and neurological damage in patients with acute thoracic and lumbar bust fractures. Its status affects the patient's management. MRI is considered the optimal means of diagnosing PLC injuries, however, being blamed for its high false positive rate in cases with extensive edema or hemorrhage around the ligaments. Additional coronal 3D PD spole to a routine MR protocol can improve diagnostic accuracy of PLC disruption, even if severe contusion exists around a PLC. Thank you.